All right. Now I'm transferring this to my Facebook normal.
So can you share the link on the group?
Yes,
or the
I will do
Facebook?
it. I will do it. Yes, I will do
So that I
it.
can send it to my secretary. He can send it across
I
to
will
people.
do it. The Zoom meeting description meeting. I will do this meeting with Dr. Rahul. Rahul on my time public. Okay. Then I will fix it. Go live. I will share the meeting with you guys. Got it. Okay. Now the meeting is live. It's going live. Yes. I'm sending you all the meeting share now. Okay.
Jennifer, you can open your video for us sometime.
Okay, I'm going to Word. I will send it to you to your okay, copy. Copy.
We were planning it, Dr. Rahul, we were planning it for two-way discussion between you
no
and
problem.
No,
Dr.
it's okay.
Azzuddin only.
Yeah,
Yes.
okay.
Yeah.
I'm sending this to you. Okay. All right, we
Got it.
can start now. Thank
Yeah.
you so much, Dr. Rahul, for having a time for this little discussion. I have like some question, and I have so many people that trying to understand exactly what you do and why I'm always talking about Dr. Rahul. So it's so special. So I prepare like a number of questions, and you can answer it. Briefly, whatever you have. Now, first of all, I know who you are, but I need the people to know who you are. Who is Dr. Rahul Bhargava?
Thank you, Dr. Azzuddin. Thank you for this opportunity to bring into the World Forum and the global players and global across talking about blood cancer. So I'm a hematologist, okay? I'm Dr. Rahul Bhargava, a proud Indian and a global citizen trying to conquer blood cancers, bringing hope to the people that blood cancer is no longer a death sentence as we used to think in a decade back. And that's the whole message is all about. And that's what we are passionate about. And that's what we live, breathe, eat, and do everything around hematology. So hematology is a science which deals with blood and blood disorders. So dear friends, anytime as we are talking, me and Dr. Azzuddin is talking, one cell can decide not to die. And that's the end of the story. That's what we think. But now we have got innovations, we have got revolutionary drugs, we have got Dr. Azzuddin, we have got people who know across the world to bring the best therapy to you. And that's what we do on a day-to-day basis.
Excellent.
Dear friend, believe me, blood cancer is no longer a death sentence. It's a statement of hope. It's a statement where we think that people can be cured if they have been picked up at the right time, right place, irrespective. I'm proud Indian telling you this, irrespective of caste, creed, sex, or financial status. We can treat anybody anywhere in this world.
Excellent. This is what I like about, the Indian healthcare. I am in the United States, and I worked with so many medical institutions here in the United States. And I know how, the healthcare system is being here, and they are very unique, but it's very expensive. And people from, for example, from the Maghreb, they cannot travel to America for treatment. It's so expensive. So I find out through my contact with some medical institution that you are at least at the top. For me, I consider you as the second, because you are following all the procedures that in MD Anderson or in the United States, or any techniques that it's new, you will apply it to your institution. This is what I like about, it's like I discover another United States elsewhere, in the Far Asia. I mean, this is why I'm always trying to talk and promote the healthcare system in India, because first of all, you are very affordable as a cost. It's not like that it's expensive. Second, it's not like that it's expensive. Second, it's not like that it's expensive. And then at least a lot of people can afford to come to your medical institution. Now we're talking, I mean, in general, just a brief presentation of the hospital, the Fortis that you work in Delhi. Is how many, the exact location and the main department that in your medical institution.
Thank you, Dr. Azidi. I think thanks for bringing us to the global forum. I think it's a boom for all of us, Indian healthcare. It's about generic. Many years back, the cheap was considered as less cost, or not being expensive was considered as that cheap, but I say it's more affordable. Everybody is not born with the kind of economy the US has to offer. It's a wonderful place to be in. But if you can implement what they have revolutionized, you can help and serve the millions of people who are devoid of the healthcare. And that's in many places in Africa, Middle East, Central Asia, or say part Southeast Asia, and even the Latin American countries where the economy is still in doldrums, and the healthcare with the rising age limits and the rising population, it is putting a real pressure on every population, every government to provide a quality and standard of healthcare to the last mile. And that's what we do on a day-to-day basis. I work in Fortis Memorial Research Institute, Gurugram, which is a twin city with New Delhi, which is 20 kilometers away from New Delhi railway station. It's one of the state-of-the-art hospitals, 250-bedded hospital, which enshrines the quality at its best, quality healthcare at its motto and at heart. And what is the thing is I would say not even tertiary, a quantum level hospital where it deals with not only bone marrow transplant, but liver transplant, kidney transplants, all kind of a complex robotic surgeries, and so on and so forth. It's one of the state-of-the-art 35-bedded ICUs are there, which is liver ICU separate, the neuro ICU separate. Neurosurgery dealing with the brain tumors is one of the best hospitals in the country itself. When you talk about liver transplants, it's one of the highest number of live donor surgeries in the world after South Korea. When you talk about the bone marrow transplant, is the largest center in India at this present moment of time, dealing with every kind of hematological problems, not only benign from sickle cell thalassemia to all complex to half-match transplants for hematological malignancies. Use of immunotherapies is very, very rampant in India, which comes at 1/10 the price which you can get in the West. So the most important thing is everybody is able to afford our Indian healthcare because of the strength of the quality generic medicines which are available. So me and my team is not me. A couple of years back, it was an individual brilliance. Now from individual brilliance, we have moved on to institutional brilliance, where we are not only me, but 12 hematologists working round the clock to bring you the best of healthcare in the world.
Okay. I mean, I had an experience with the Fortis Hospital with Dr. Anand Sinha, who is a pediatric surgeon who did an amazing job on a child. The child, I sent this child, he was no hope. In Algeria, vascular surgeon, they told him just stay at home and pray, and there is nothing that we can offer. So when they called me, I tried to save him because he doesn't have a lot of money to come to United States. And when I sent it to him, he got like another life. I mean, the child is doing excellent and he's living his life. He was bleeding from a vascular tumor. It's impossible to take out, I mean, from his body, more than 1 kilo. And the baby is like 1 year old, I mean, a kilo from a baby, it's huge. So This is why I'm very interested about Fortis and about what you are doing. It's really unbelievable.
Dr. Azadine, it's a quaternary structure. It's a quaternary. It's not even tertiary, which deals with the highest order of complex diseases which a God has to offer to human beings.
Okay.
So that's what these doctors, which are like 300 doctors, works together on a day-to-day basis to bring life, and what you have just narrated, bring hope and happiness to the families around the world.
Sure. And then tell me about your specialty, exactly what you do, what's your main interest, what do you see patients in your daily practice?
So I'm basically a hematologist, hemato-oncologist, and bone marrow transplant specialist. We are two people, Dr. Vikas Dua and me. Dr. Vikas Dua sees from 0 to 18 years of age, and I see from 18 to till the time you're alive, any hematological disorder which comes in. So let's say benign disorders like anemia, low platelets, high platelets, low WBC count, high WBC count. When it comes to aplastic anemias, where all the lineages have gone down and your blood is not being formed and you're bleeding from somewhere, those are the benign disorders which we see. Then sickle cell thalassemia is Dr. Vikas Dua's frontier, where he sees sickle cell every month. He does 10 transplants for sickle cell and 3 to 4 transplants for thalassemia across the world. Then primary immunodeficiencies, then brain tumors is very, very common. That's what we see on a day-to-day basis. When it comes to my adult side hematology, anything to do with acute leukemias, CMLs, chronic myeloid leukemias, myelodysplastic syndrome, because as we age, we keep on getting these cells going berserk and causing the problems. Similarly, multiple myeloma, a tumor form which arises from the blood but affects the bone. Lymphomas, any swelling in the body which you see on a day-to-day basis, you can get to a lymphoma. And not only we get restricted to this, but we have got an IT specialist, infectious disease specialist, who deals with anything and hematology with HIV to have to be done. So HIV, tuberculosis, and pyrexia of unknown origin, where the fever is not going. So many people, like 2-3 weeks, the fever is not coming down and you don't know what is happening. That also comes within us. Then there is another thing, which is geriatrics. Anything above 60 years of age, geriatric problems, geriatric cancers are being dealt with, because these people, as we grow older, they have got special needs in terms their body is not able to tolerate as chemotherapy as young guy of 35-year-old will tolerate. So modulating according to the geriatric scores, you can give a tailor-made therapy to them. And not last but not the least, the geneticist, which is the heart of our operations or department, because they tell us why me and Dr. Azadine is different. Why you develop diseases? Will your kid have diseases? Will your brother, sisters will have diseases, and how to manage them? So geneticists is a very, very important point, because they help in deciding the right chemotherapy for them according to their genetic profile. And these are the group of 20 people who work together for years together to make this a successful and a beautiful story.
Excellent. And I know that you're also among the disease that you are treating multiple sclerosis. And there is another disease that it's not the same, but the amyotrophic lateral sclerosis. People calling me for these two pathology, and I told them it's not the same. People, they are saying that it might have another treatment like stem cell treatment. You have to tell us the difference between the multiple sclerosis, which call in French sclérose en plaques, et l'amyotrophic lateral sclerosis, amyotrophic lateral sclerosis. So tell me exactly the difference between them and why one is accepting to have like a stem cell and the other no.
So Doctor, it's a very nice question, a very apt question. So multiple sclerosis is an autoimmune disorder, dear friend, where your own body cells are killing the neurons, leading to the loss of function because of the death of those neurons or the brain cells or the brain waves or brain, or you say the neurons, what you call as. While amyotrophic lateral sclerosis, or what is called as ALS, is a degenerative disorder. It's not an autoimmune disorder. It's a degenerative disorder in which the cells have started dying because something inside the cell has gone bad and they are not able to survive. Why multiple sclerosis? Because these are autoimmune in nature. I can bring an external agent and remove the autoimmunity. But in ALS, because of the degenerative its nature, I cannot fix the cell. And remember, stem cell transplant is not stem cell therapy. Stem cell therapy is where you take the stem cells from somewhere and inject either in the spinal cord or in the knee or in the heart or in the brain, thinking that these cells will grow into those respective cells. So that does not happen. And bone marrow transplant is in multiple sclerosis, specifically what is called as autoimmune disorders like systemic sclerosis or multiple sclerosis, Crohn's disease, rheumatoid arthritis, SLE. These are the autoimmune disorders. I bring an agent which suppresses the body's immune system, take the stem cells, preserve, suppress the immune body system, kill the B and T cells, and put the stem cells back in, allowing these stem cells into the milieu of these immunosuppressive agents to grow normally. So dear friends, MS is amenable by bone marrow transplant, 80% success of stopping. And after that, no medication. It is just that the disability should not happen. If you lose your eyes, I cannot bring that eye back. I can stop that eye from getting bad to worse, but I cannot make it bad to good until unless you come to me early. So that is why we are saying that multiple sclerosis from across Europe, across US, and it's not expensive. It's not crazy expensive. And you can get it done safely with the same protocol which Dr. Richard Bird has used. Rituximab, cyclophosphamide, cetoxan, and ATG, which can be utilized, adopted, 110 patients done, and 80% success. So please remember, degenerative disorders like Parkinsonism, ALS, Duchenne, they're not amenable to stem cell therapy. But autoimmune disorders, yes, we should try to get the transplant early, because ultimately what are the other drugs doing? They're all suppressing your immune system and continuing the drugs forever. While in bone marrow transplant, it's a one-time procedure.
Yeah.
So I think MS should be amenable for transplant, and we should adopt early rather than late.
Yeah, my question comes after seeing a patient. He was bringing like an opinion from a doctor in, I don't know exactly from where, and they were telling them, yes, we can do in ILS, we can do the stem cell. I told him no. I heard something from Dr. Rahul. We cannot do this. It's not like, and then you just explain now why it's different. So I'm just preventing people not to go, jump, just for money and throwing their
Absolutely.
money. Okay, this is great. So is there any other treatment like after like stem cells before patient, for example, for the leukemia, when you have like patient with leukemia, is there only bone marrow transplant who is going to fix the problem, or is there any new medicine that they can start medicine and they can get cured without getting the transplant?
Very nice. Again, very, very relevant question, Dr. Azid. And I think you are becoming a 3/4 of a doctor. And you on the other side also, you understand the patient pain. So you are a deadly combination, because you know the doctor stuff as well as the patient
I did a
stuff.
lot of things. Yes. My
Yes.
issue was always the complicated case.
Yes.
And always trying to find a solution.
So in acute leukemia, anytime you develop acute leukemia, dear friends, what happens? Your genetic makeup undergoes a change and does not follow what the God has planned for you to walk into a straight line. So Dr. Azidani is saying, is all leukemias get a transplant? The answer to that is no. Not every leukemia needs a transplant. Who requires a transplant and who decides it? It is the genetics of your leukemia which decides itself that whether you require a transplant or not. Okay. So there's a 922 translocation in ALL, you'll require a transplant. While there's a 821 translocation or inversion 16 or 1517 translocation in AML, you don't require transplant. So 20-30% people in AML do not require transplant, dear friends. You can be cured by 4 chemotherapies. First, second, third, and fourth.
Excellent.
But you need to know the genetics of your thing. Majority of time, what I see and what we have seen and experienced is the genetics is not available. And that's what we are trying to work out with our partners in various countries, how to establish, how to strengthen the genomic testing. Treatment is one thing. If I know your genetics well, then I can prepare you on day one, which is like 13th of March, I can prepare that you might require a transplant in May. You can gather money, you can gather your friend, you can take care of your heart, lung. But majority of time, what happens is your genetics are not there. You get chemotherapy, you relapse, and then you get a transplant. The outcomes goes down.
Okay.
If you do on a clean slate, that if your genetics is high, say monosomy 7, I have decided you require a transplant. I do an HLA typing. I collect money for you. I take care of your heart. I take care of your belly. I take care of your food. I take care of your muscles. I ask you to walk 10,000 steps every day. Pick 2 kgs of weight every day to build your muscles. And then do a transplant after 2 months. The survival will be 80%. So the short answer to his complicated question is, the answer lies in your genetics, one. How you respond to the treatment, the answer lies to that. So if I have a bad disease, if I respond well, I will not require a transplant.
Excellent.
I have a good disease, I respond badly, I will require a transplant.
Right.
So very, very important. The criteria is genetics, MRD, minimal residual disease, your outcomes depending on the chemotherapy, how you have responded, and the underlying problems in terms of infection where you're not able to carry on the chemotherapy, and that's why you need to be given. So dear friends, what is more important is there is never all or none. There is never 0 or 100. It is somewhere between. So AML, 70% will require transplant. In pediatric ALL, probably less than 5% will require a transplant. MDS, yes, people will require a transplant. Myelofibrosis, 60% will require, 40% will not require. CML, probably less than 5% will require a transplant. But other than that, they all can take up a oral medicine and they can continue. That is why if you have a limited finances, please plan your therapy very well. Because the most times happens is you keep on spending on chemo, where you require a transplant and you don't get a transplant. By the time you relapse, the only way for you to go ahead is do nothing.
Excellent.
Because you have finished all your money. So that is why the risk stratification is the paramount important thing in hematological malignancies.
So each case is different. Each case has
unique.
His own plan of treatment.
So Dr. Azadeh looks so beautiful, and not me. It is the genetics will decide who will look good and who will look bad.
Sure.
Okay.
Sure. So the genetic will decide. Yeah, this is another question. Yeah, I mean it's clear. Thank you so much. And then, I am from Algeria, and I love my country. I love that my country start like treating all these diseases, and especially in the Maghreb also. I mean, I travel in all the Maghreb, and there is this problems. Patient. Maybe the mortality rate is the highest in Africa, and especially in the Maghreb. And is it possible? I mean, this is a question. I mean, I don't know. Do you have like a program to train young doctors from this region?
Yes, very, very, very nice. Because the thing is, the legacy will only be created if you keep on passing what you have learned to the new generation.
This is the American way.
That's how it is across continents, across oceans, across mountains. As a whole human creed and breed, we need to share our knowledge of what we have earned and what we have learned in this world. So we strongly believe in this association of knowledge sharing and learning together. There are many things which you have taught me, Dr. Azadeh. There are many things which we keep on learning from every day. Learning is a continuous process. So we do have this where we can train these young doctors who are going to be the future for Algeria and for your love of your country. We can always do that. And we keep on doing with Dr. Reddy's in Algeria. Because Dr. Azadeh, I'll just give you one thing. I remember we all went to Amsterdam, and the doctors from Algeria also went to Amsterdam. We launched rituximab for Algerian doctors in Amsterdam. So we have Dr. Reddy's who works in Algeria for rituximab for lymphomas and other indications. And we know a couple of Algerian doctors which we have launched the product together. And on this 18th of February, we had one seminar with Algerian doctors where I pre-recorded the session on lymphomas, the real world experiences. So I think it's a wonderful association. I think Algeria is calling me, and I think it's a wonderful time that we should collaborate to teach the people online so that the future is brighter.
Thank you so much. And then the last question, this is very important. If the opportunity arises, are you ready to visit and collaborate with the doctor in Algeria and of course in Morocco and Tunisia and all that? You will tell them exactly the tools, you will prepare them for some big things. I mean, I don't know if...
Absolutely right. So we are very, very open to travel to our fellow people, fellow colleagues who talk the same language, the same lingo. We feel happy across any hematologist in the world we meet. I think it will be a great opportunity to learn from various communities, various societies about how the hematological malignancies are being treated and reaching on to some uniform protocol where we have learned from our own experiences with so vast majority of 1.4 billion people. It will be helpful for each other to gain these experiences, which might not be written in the books, but you learn through the practices of years together. So I think it's a great opportunity, dear friends. Please feel free with Dr. Azzedine. If you have even one patient to discuss, we are open to discuss at this time because this is the time where we come back home and have a cup of tea. On that, we will be more than happy to discuss any case which you have. Please feel free. Myeloma, what is new
myeloma,
happening?
yes. I have a patient. I have a patient with myeloma who is going to Turkey for treatment, and he always telling me, "Please get me like a second opinion with the doctor that you know." So I mean, I will connect him directly with you, so you can talk to him directly. And thank you so much for all this valuable information. And I'll let you conclude whatever you know you have to say, if you have something you didn't say before, so we can finish this this interview.
I think it's a great opportunity. What we have started today, we like to continue this in the future, bringing out the knowledge sessions to the general public and removing out and busting the myths about blood cancers. We bring hope together in this diseases which can affect anybody, anytime. Please stay tuned to this Facebook page of Dr. Azzedine. And we are hopeful that together we will make a difference in the coming years in the lives of blood cancer patients suffering from blood cancers. So let's be hopeful. Let's talk together. Let's work together to beat blood cancer.
Thank you so much, Dr. Rahul. And then we're going to be finishing. I'm going to try to stop the recording so I can send it to my colleague Jennifer. She will be maybe doing like some translation on it in French or in Arabic. This is it's a good material, and I think we'll be sending it to you very soon. And thank you so much for all this organization and for your availability. And we'll do it with other doctors, of course.
As well, yes, definitely, Dr. Azzedine. And thank you so much, Dr. Rahul. Thank you so much, Dr. Rahul. Thank you so much, Dr. Azzedine, for your precious time. Yeah, it was great.
Thank you so much. Thank you so much. Have a great day, sir. Okay, thank you.
Good night.
Thank you.